I have a question to Dr. Well. I would like to thank him. And regarding the differences in or matching of absolute blood flow determination between PET and SPECT. Of course, this depends upon many factors. One of them, for example, the ring detector, for example, and the attenuation correction also. I have a question. Did you notice any difference in regional blood flow with attenuation correction and without attenuation correction? This is number one. Number two, also the type of radiopharmaceutical or radio tracer. Regarding thallium, I guess is more approximate to rubidium. For this reason, which is more correlated for the blood flow is thallium or technetium lipophilic agents. Thank you.
Okay, thank you very much for those questions. Those are excellent questions and certainly areas that we are both worried about and looking into. Regarding the attenuation correction, we did look at that in the animal studies and with our human comparison studies. And with those, what we saw for global imaging, yes, you can get away without any attenuation correction. Once you start looking or trying to look regionally, that's where you start to see attenuation effects coming in. And that's where we think attenuation correction may help. You're not completely lost without attenuation correction, but you still see the same sorts of attenuation artifacts you get with standard perfusion imaging propagate into flow imaging. And so you're going to see decreased apparent uptake in the inferior wall, leading to affecting flow in that region as well. So this is something that you do need to be very careful with. We think you can do a lot without attenuation correction using global values, but if you want to look regionally, you're going to have to be much more careful. Regarding the use of different tracers, we did not look at using thallium in the clinic with humans. Other centers have looked at doing thallium imaging. There was a bit of work out of Yale as well, looking at flow imaging with thallium. The reason we've been avoiding it is just because of the patient dosimetry. It is a better flow tracer, but you need enough signal to get good measurements, and that means larger doses to the patient. So you can do better with these cameras. They do have better efficiency. So you can use low dose thallium protocols, and there have been a few places, I believe in Asia as well, that have approached this, but most centers are hesitant to go back to thallium and really prefer to use the technetium-based tracers. And fortunately, we're getting some good results with them. And so we're using that primarily from a patient dosimetry viewpoint. Thank you.
Good, thank you. Matthew?
Thanks all for the great talks. Question for Eugene. So you talked about the pendasign with gallium, lacrimal and ciliary glands uptake. So we don't really see that often with FDG, right? So why don't we see more pendasigns with FDG?
There's probably, but no,
that's a great question. Wonder why sometimes you don't see it, but I mean they're slightly different tracers, right? They target different things. Some target gallium is it's an iron analog. The FDG is just targets. They're different targets, so that may explain a little bit why you don't see the pendasign. But certainly, if the salivary glands are inflamed and like in Sjogren's syndromes, you might see it. But so it's probably just the difference in the tracers and what they actually target.
thank you, Eugene. Next question.
Yeah, my question is mainly to Dr. Wells. I guess from the perspective of community practice, SPECT myocardial perfusion, and that's a lot of extra camera time. We're moving to the point where a lot of community centers are getting more CZT cameras, or with Veriton and Starguide Health Canada approved. Now, I'm sure that those are going to come into some centers. We might see more push for this. I do a lot of patients. I don't know how I could possibly do all of them with quantitative flow. How would you allow for patient selection, or who would you target this towards, I guess?
So that's also a great consideration at the Heart Institute. We don't do it on everybody. We do only do it on probably 1 or 2 patients a day. And those are pre-selected, I guess, for patients that are going to give us the best information. I might actually turn this back over to Dr. Ruddy because he's going to be able to give a much better clinical perspective on which patients and why we choose them. But the essential idea here is to get patients where it's going to be a benefit. The flow is going to help us identify patients at high risk of multivessel disease and situations along those lines. But I invite Dr. Ruddy, please, to comment on our particular choice of patient selection.
Glenn, I agree with you as always. You have to select the patients if you don't have much time. What we're hoping is our turbo protocol, where we use the dynamic images which are acquired during the injection of the radio tracer, can be reconstructed with adequate quality and not need delayed imaging. So the protocol would be imaging during the rest injection, wait a little while, imaging during the stress injection, and then prone, and then you're done. So that protocol is like a rubidium PET protocol, which would be 45 minutes. And if that works out, that would be very good for blood flow imaging, but also be very good just for routine rest stress SPECT imaging. You could do exactly the same thing. So meanwhile, we select patients, 1 or 2. We also have a great PET program, thanks to Rob Beanans and Rob DeCamp. So it's sort of hard to sell a second level of quality program. So it's really patients that we do to help us with the SPECT studies and also perhaps decrease the wait list for our PET studies, which is long. Yeah. Okay, Ron?
Thank you. I have a couple of questions for Eugene. We have a very large sarcoid program at Rochester, going back 10 years now. And we're seeing patients who have, and we do an 18-hour fast, followed by 2 ultra low carbohydrate meals. So our preps are good. We're seeing maybe in 5 or 10% of patients sometimes some degree of aortic uptake. And I'm wondering to what extent you think that might be due to atherosclerosis or some other type of vasculitis, or could that be a normal variant? Number 1. Question number 2 is, how often do you see active FDG uptake in patients with negative MRIs?
Those are great questions. So the first one, so we do see sometimes incidental uptake in the aortic wall. I suppose with newer cameras, as we heard, it's even more common to see it. Typically, unless there's a clinical question, as if if there's some sort of reason to suspect aortitis or vasculitis, we'll just blow it off as atherosclerosis maybe. But if it's really prominent, then you might wonder. It's not that often we would see it, but again, maybe with the newer digital cameras, you'll see it more often. Just need to be aware about it. The second question was normal MRs and active inflammation. That's hard. We actually do, in the majority of our cases, have cardiac MR with ours. So I'm just trying to think what the population.
We're fortunate.
Oh, sir.
Well, I mean, Rob Beanlands can speak to this. They've actually done a study looking at the sensitivity specificity of PET versus MR, imaging completely different things, right? So FDG has to do with inflammation, MR is scar imaging, and potentially edema. I don't remember the exact results, but if I remember correctly, MR was less sensitive. Rob, is that right?
Yeah, Dr. Wiefels.
Yes, exactly. So depending on the stage of the sarcoidosis, you have a patient presenting the early phases of sarcoidosis. Sometimes you'll have a normal perfusion and normal MRI as well, unless of course T2 is evaluated and showing increase and inflammation. But when you talk just about LGE, the early phase of disease, it will be normal, and then the FDG PET will be abnormal. And sometimes we have those patients coming with the MRI that it's normal, but the patient has clinic history, has a heart block, and also other lymph nodes that are suspicious for sarcoidosis, and then we'll do FDG PET.
Quickly, first of all, great talks, everybody. Question to Eugene. You talked about not using absolute thresholds. Is there any value in using relative thresholds? For example, 1.5 times the LV cavity or LA. That's one. Secondly, about patient selection. I think, sarcoid is one area that I think patient selection is really important. You have these patients with extracardiac sarcoid. That's sort of relatively easy. You have patients with a high pretest probability of sarcoid. But then we get referrals for these patients where the pretest probability is very low. And they say, okay, let's just do a PET study to exclude sarcoid. And those are sometimes really difficult, hard to interpret. And I wonder whether, even imaging that group of patients is useful. Do you guys screen your referrals and not do patients unless the pretest probability is at least moderate?
Great questions. Yeah, we do. A lot of our patients, we entered them into the cadre. Yeah. So there's two ways. I mean, one is the ones with pulmonary sarcoid, and that's obviously a higher pretest. The others are the ones that have heart blocks and come in. I don't think we've typically cut out many of the patients that screen out, but they are assessed on a provincial committee where we look at these requests and to decide whether they should be done or not. Because you're right, if you take all comers, there's going to be lots of reasons for there to be uptake in the heart, even coronary artery disease. It's a big problem with assessing the patients. A lot of times they do have coexisting disease, and that just makes your findings very non-specific. So you're absolutely right. You need to choose the right patient. Relative threshold, there's a lot of debate there. I mean, some different centers do different things. Some places you compare it to liver, some places compare to blood pool. I think the jury is still out on that. There's no real firm recommendations that I'm aware about. But if it helps you at least be consistent in terms of serial reads, I think that might be helpful.
If I can answer as well, Dr. Soman. So we have the special access program in Ontario, and we do screen those patients. We have a predefined list of what we consider as criteria for the PET to be done. And normally the patient, it's following the guideline as well, the patient with whether presenting with heart block or arrhythmia or sudden death, those patients will be directly done for a PET-CT. Doesn't matter if there is an MRI or not. Also, patient presenting with heart disease, with heart failure, for example, and the MRI showing areas of patchy patchy late gadolinium enhancement that are suspicious for sarcoidosis, together with other findings on CT, such as a lymph node or lung sarcoidosis, those patients will go as well directly for PET. We have also physicians that are revisor of those criteria, and we receive emails to acknowledge if the patient can proceed or not to the PET. And sometimes we do see patients coming just because of heart failure and an MRI with the one focus of a late gadolinium enhancement, and the PET reader says, the MRI reader says this is non-specific, cannot exclude sarcoidosis, and we end up doing the PET, and those patients tend to come as negative. So we are starting to do some evaluation of those criteria to see whether it was beneficial or not to do the PET. So we're just starting this at the moment, and I think we'll be able to screen a little bit better in the future, and perhaps those patients coming just because a reduced LV function and one single late gadolinium enhancement might not benefit of a PET at the moment. And regarding the quantification, we're also starting to do a revision with Dr. Sharon Tatawi regarding the different type of quantification. And at the moment at the Heart Institute, we do not use any type, any criteria. We're based solely on the distribution of the FDG and the clinical history. But I think there might be a value, the quantification, the ratio to the liver, the ratio to the blood pool. There are a lot of type of quantification, and I think we're going to do a great review on that soon for the JNC.
Thank you, Christian. Now, a question for Gary Small. I agree with you that education is very important. We need competent trainees. That we need that for our stability in our field. What impressed me was the variability in the learning. We definitely had some quick learners and some slow learners. It's the slow learners I worry about. So can you use some technique to identify slow learners, or do we have to treat everyone the same and treat them all like slow learners to make sure we get the slow learners up to speed? Gary?
Thank you very much. Can you hear me? I hope you can. So a great question. I think that that's the beauty of using the tablet kind of documentation that we have here, is that by reviewing learning after every 50 cases, and one can see the trajectory of the learner. So you're able to pick up, you know, which learners are moving slowly and which ones are moving fast or learning fast. Whether that will equate to a change in training time, I think will also depend on, you know, the idea of service and training needs. You know, that's always one of the problems when you have trainees involved in a program, is that there is service commitment that their training, you know, almost mandates, and it's always it can be a bit of a conflict between the two. The idea is that it's a happy marriage, that there's a service commitment as well as the training that go hand in hand. So I think, to answer your question, I think the tablet method lends itself very well to identify those who have different learning trajectories. Thank you.
Thank you, Gary. Now, Ben, just a question for you. Coronary artery disease is evolving. Like the cath labs show that we've less obstructive disease. We're seeing that with stress perfusion imaging too. So should CT evolve? Like CT is really designed to find stenoses. Perhaps we should be moving into like the flow reserve area in CT, or even more into the plaque characteristics.
Yeah, so CT is the newcomer, but it's actually, I'd say, grown exponentially. So the current focus is, at least in research, was initially coronary disease. Then the next is plaque. Well, sorry, I should say they've done fractional flow reserve, so FFRCT. Now we're looking at plaque. There's been some interest in dynamic acquisition, as you mentioned, and with that, you can potentially look at perfusion. And then the next goals, as you mentioned, and I'm working in collaboration with colleagues in Australia, where using CT perfusion maps, can we actually emulate MFR that we get on PET? So that is an area of exploration. I'm not certain if we're anywhere close to, I guess, prime time, but it is areas of potential interest.
If I may comment, FFR, CT, FFR, I mean, it's a computational model, and I'm not so confident with it, actually. There was this study in England, Scotland, which has a heavy CT bias, and the clinical application of CT FFR had a diagnostic accuracy of 60%. So the question is, can we use it? I mean, according to these data, I wouldn't use it.
Scott.
Yeah, I think it highlights the slide that I showed, that there's a greater inaccuracy at that threshold of 0.8. And if you actually look at the agreement's 50%. So if you're falling in that gray area, you may as well flip a coin. So most of us clinically, at least in Canada, because we don't have ready access, the answer is easy. Even clinically, if I had access, because I do perfusion imaging, I'm much more confident in perfusion imaging. And our current clinical practice is when we have moderate lesions or equivocal lesions, we refer them on to a functional test of some sort. But I would agree with you. I think do you believe the vendor or do you believe the literature? That's one of the confounding issues, unfortunately, at this point.
Thank you.
Very good. So I'd like to make some comments and some thank yous. First, I'd like to thank our speakers for their excellent presentations and the audience for their attention. These morning sessions have featured speakers who've worked with me in cardiovascular and nuclear medicine, locally here in Ottawa and internationally. I'm very grateful for them taking the time to present at this session. I'd also like to thank Dr. Lionel Zucchier, past chief of nuclear medicine at the Ottawa Hospital, for imagining the symposium and then planning the event. I thank Dr. Francois Lamoureux, president of the CANM, who's been a friend for about 30 years. Drs. Andrew Ross and Jean-Luc Robin, co-chairs of the Ottawa Scientific Committee and the 2023 Annual Conference Committee, for supporting and organizing these sessions. Over the years, I've learned that People make all the difference, and they determine our success and also, probably even more importantly, our joy of our experience. I've also learned that working as teams markedly improves our productivity. Teams need to be multidisciplinary and diverse in many ways. I've had the opportunity to work with so many wonderful individuals and on so many successful teams. In nuclear medicine here in Ottawa, we implemented oncologic PET, which is a big effort about 15 years ago, and a nuclear medicine residency program. So we created a new program. In cardiac imaging at the Heart Institute, we developed a world-class clinical and academic program. We've trained many multimodality imaging experts. Internationally with ASNC and with CANM'23, we've developed guidelines and consensus documents and organized many educational events. I'm very proud of our accomplishments. I'm very grateful to have been able to work with so many tremendous individuals and on so many productive teams. So I thank everyone for attending this symposium.